And what we want to do by the end of this is to have, again, a fairly good idea of what we agreed upon, main points, where any major takeaways, what are the gaps that remain that we need to fill, and that's going to inform our future research agenda. NIA, National Institute on Aging, will be expecting this in terms of not only our annual report, but also in terms of the proposal that will be submitting the second competing renewal application to be able to fund the results of this item. Okay, future interest. So this is really important. I'm glad you're all here. So keep eating, but as we keep eating, we need to keep talking in terms of facilitation. So I've already collected some folks who were unable to participate, and they've provided some of their answers and ideas to these questions, but I want to hear from the rest of you. We'll start here with the first question, which will, and we'll be looking at these facts that we learned and see if we are all in agreement on it. All right, so let's start from the beginning. And actually, I'm going to start off with one fact here that was provided specifically regarding the persistent evidence for an immigrant mortality advantage. We've heard a lot about that, not only in the past couple days, but throughout our different installments. The question is this expectation going to, in terms of this advantage, going to diminish? We have some evidence presented by Phil Cantu that this is not even the case anymore. Lots of different hypotheses on whether this is going to persist. So let's begin the conversation. That's a big issue that I know the other ones I have now in terms of what our consensus is on that. So this
Isn't there a clear consensus that we just need the data to find that out because we don't really know given undocumented status in most of it, but that's something that was, I thought, a conclusion in Maureen's talk that I appreciate that, but I'm not really sure I know all the data points.
Others want to comment? Yes.
So today I wonder is the why do we believe this mortality advantage is happening? Because if it is for a genetics differentiation, it should persist. As long as they keep being Hispanics, they have Hispanic heritage, if it's a genetic advantage, it should persist. But if we believe it's a health behaviors, lifestyle, as the acculturation, if they get more acculturated, more lifestyle like in the US, it's going to decrease and most likely going to be similar to the US citizens. So I think the question on that is if it persists, depending on why that advantage is happening.
So we not only need the right data sets to document it, but also the more testing of these hypotheses. Now, I mentioned that Elizabeth Arias, the National Center for Health Statistics, is going to be publishing her new estimates at the end of this year, early next year. And those will be specifically looking at the Mexican origin population. There's one disadvantage in many of these data sets is we don't have the subgroups represented. And even though the comment and the observations made that the Mexicans were accounted for much of the disadvantage, that's not really exactly as precise as we'd like to be built.
Well, one thing that was glaringly missing in all this that we've discussed was the role of poverty in creating, an accented effect, on vulnerability for both disease and mortality. And if we indeed continue to have this trend that was just discussed, for example, of increasing, diabetes, increasing obesity, increasing diabetes, and then the ancillary, factors that come along with that, such as higher disease rates for if we get it, the cardiovascular. I think that the interaction is really going to be, and the pathway for that is going to be through poverty.
And just to sort of extend that argument, also for non-Hispanic whites, because we're going to have those approach retirement, the haves and the have-nots. So we see persistent decline in that population.
On the same trajectory, as we are evaluating the economic resources, et cetera, of collecting populations, especially immigrant populations. I think it will be important to look at really consumption overall, especially as they're coming into the U.S. Economic and banking markets with increased access to credit, with increased ability to consume perhaps beyond means or consumption that really goes beyond the income that we're seeing. So to not strictly look at income per se or poverty, but to really look at consumption overall.
Yes.
I mean, it's an interesting idea that poverty is the relative disparity in poverty is going to drive poorer health status. But isn't there some data existing with the remittances and what we're spending on, what those folks are spending on, and the fact that the amount of remittance isn't attenuating or isn't creating better health for the Latino families back home? I mean, I thought that was a fascinating talk about the elders left behind and how that's, even in the case of being enriched,
Yeah.
that amount of money didn't help.
Yeah, but
Those
I'm
elders
talking
in
about
Mexico.
I'm talking about in the United States.
Right.
And because that population you're talking about is also the one that doesn't have health insurance, is not entitled to it under ACA.
You and I are on the exact same team there.
So we have consensus. So related to this point, I'm going to piggyback off this next fact that was learned to see if we come into an agreement. There are important potential intergenerational impacts to be considered for the health of older adults in Mexico, although in the direction of child to parent, including adult-child education and migration. So this is the whole question about how is education affecting, or is it what returns to education for these intergenerational relationships, including financial intergenerational exchanges. So this gets to your point, sort of what's going on with is it child to parent, and also the amount of remittances for that exchange. To me, it needs often isn't captured, and MHAS certainly has the data. And Rebecca, you've worked a lot with this, so are you in agreement with this comment?
But what is the statement, the conclusion? What is the fact?
The question is, there seem to be potential intergenerational impacts to be considered for the health of older adults, but most of it is coming from the positive effects of children's contribution to the health of not so much older parents, access to services.
So that there might be some, perhaps, health benefits to the immigrants coming from their children, whether the children are here or in Mexico?
Because it seemed to be that the children who were far away from their parents who were far away from their children, vice versa, were not doing as well, right? So,
And then, and this is part of what Patrick Sanford said, there are a lot of things changing in the future. One of the things that is changing rapidly is education in Mexico and other Latin American countries. And so the education of the children will be much higher in the future.
right, so this adult-child education would be the piece of this. Is everybody in agreement with that observation? That there'll be a lot of change and potential returns to those education. Especially for women. All right, let's see what else we have. That was the second point here. Southern Road differences in Brazilian maternal mortality largely related to educational changes. Is that correct? Okay, we're all in agreement with that. Trajectories of depression related to the onset of disability.
That was good.
Yeah.
It's just
Yeah. We don't need, the problem with that is we don't know if it's physical or cognitive. We know it's
Yeah.
cognitive disability
interesting.
or cognitive function. You would speak to this.
I thought that,
Depression is a fairly well documented prodrome of Alzheimer's disease, so,
Yeah.
and I say fairly well, it's not understood.
Right.
it is a pretty established association in a quarter of the population that will develop MCI, will also suffer a depressive late life episode, and it's probably associated with a previous life episode of depression.
Do we have enough data at this meeting to support that?
Well, what I thought was, a conclusion could be that there's a lot more to do on mental health. I mean, people kept saying, we don't have enough, we don't know enough. It could be mental health, it could be depression, it could be, but it wasn't enough to make a clear statement.
And an important part of this installment has been to look at dynamics and change over time. We also don't know about changes in social support and social support trajectories and how they're affected by these outcomes and changes in cognitive function. Terrence's the work they've been doing also speaks to that, and there's a lot of work along those lines. So on both sides, not just changes in functional, but changes in cognitive function. This comment was kids' migration is related to mental health. I think we're all in agreement with that. It's a broad statement, but anybody want to weigh in on that in terms of agreements, disagreements? Very, very, very broad. Yes, Janice.
The intergenerational idea and the idea of familism and whether that changes with the generation or not would be interesting to explore more in depth.
And what keeps coming up at our meetings is how do we define acculturation? Is it narrow just in terms of language proficiency, or is it much more broader than that in terms of ethnic identity? Yes, Bill.
Well, not specific to the acculturation one, although I have strong feelings negatively about getting into that morass, because I've been in mental health research for decades, and I can tell you that that's a dead end. Okay. So, but anyway, moving on. I think the family reformation issue is something we don't really understand the consequences of very well. I mean, the family formation and reformation, the people coming to this country, for example, and they come alone, and they start families, or they have to bring families that are put together on this end, or they have to go back and reestablish families. And this has this emotional cutoff, fracturing of families has enormous impacts on these families, which we really know very little about, especially as it relates to aging members and the consequences for them. Because they're coming over and they're leaving people behind. And sometimes they're married, or they have families at least in Mexico. All of that we know very little about the impact. The studies that have been done shows it's very big impact. The limited studies have been done mostly in Mexico on the families that are in Mexico and have people leave. You know, a major member of the family leaves, a parent leaves. The family that's left behind, especially if it's a woman with children, Borges has studied this in Mexico and seen very big impacts negatively. And it's behavioral problems with the children, especially the boys, and depression in the women, right? And so the consequences of that, if the person comes back years later or whatever, we don't really understand how all that begins to fit together. And probably our colleagues in Mexico can give us a lot more information about that would be very useful to build on. On this end, we also have no information.
So what I'd like to now do is turn it back to you in terms of what you've written so far under the facts that you've taken from the meeting, so we can add to this. Anybody want to jump in, share with us? Yes.
One was the Association of Insurance with Longevity, and it brings up insurance as an important topic here or in Latin America.
Very different based on the context, which didn't really come up as much as it has in the past, but really is a critical feature, right, of understanding health coverage and how it affects mortality, morbidity outcomes. Agreement on that? All right. What else we got?
Shall we go to number 2?
Oh, let's go to number 2. What gaps remain to be filled in literature? We started in one bill. We can add a point there about more studies looking at characteristics of our migrants, coming and going, and how are those factors?
Family impacts.
family impacts of those support systems? Are they undermined for those who are left behind? Does the paradox still exist and for what populations? I think we're all in agreement with that. How will changing health context of immigrants change health selection? Or how will changing health context of immigrants change health selection?
That's a good point. I mean, are they getting more selected for medicine?
And is that because of immigration reform, or what is the problem?
Changing
Yeah.
barriers,
Policy.
tougher,
Family institutions?
you know, no reason.
So we're saying that they're constantly changing attributes of who's coming in and why they're coming,
Well, they're changing epidemiological context that they're coming from, too.
right?
Right.
The characteristics that they're coming, bringing with them. We don't know if the more obese or the less obese are coming.
Well, if it's less obese, they may still be more obese,
Right,
even though if they're
right,
less
yeah.
than the
But,
population.
and less obese than the US population.
But they may be more
More
obese,
obese
anyway,
than-
yeah.
And there is something called more.
No, and I guess related to that, is there a way to better measure, capture the undocumented workers, the health status of
Yeah.
undocumented workers in the U.S., which we don't have such good information. We don't know what kind of biases it's generating in the studies we produce.
Legal status.
Good
We
one.
have the Mexican Migration Project, right? That's certainly, and that has come up in the previous installments. Just how does one, take the next step, and how does that work?
I think you've heard a little bit about biomarkers and inflammation. There just isn't a whole lot in the literature, and not a whole lot here. So,
We had our volume back for our 5th installment on biobehavioral aspects.
right, we did.
But it's very thin, so really there's a lot more work to be done, and Noreen's presentation, I think, understood that
Yeah.
point.
The thought that I've been working on to try to articulate is, what is the causal mechanism between mortality and disability within this paradoxical group? And the biomarkers are probably key to this understanding, but it seems to me we can document the mortality in so many different places in so many different ways, but yet the underlying causes of disability and living with disability longer seems to me to be the more important issue now. It's not that the paradox does or doesn't exist, or persist or will not persist. Frankly, it's living with that disability is the more important focal point from a direct care kind of perspective.
So we have sort of a demographic perspective and then sort of a sociological, psychological consequence of how does one deal with protracted disability.
Well, how they survive with a disability would tell us a lot about how to intervene in
How they
order
cope.
to ameliorate the
Yeah,
disability.
influence
Well,
on
and
the
how the
Yeah,
families are
that's,
supposed to
I think
do
that's the part that I didn't articulate as well.
And something related, I don't know if it's not the forum, I mean, this is my second meeting, but, so how the services play in terms of disability? Onset, if you get better or worse, and through the life course. I mean, especially we're talking about comparing Latin American countries with the US. And within Latin America, I mean, Costa Rica is very different from Mexico or Brazil or Argentina. So those, having access to something, not just insurance, but, really what you have access to in terms of services, health and social services. And how does, what impact it has on how do you progress into aging, or once that you have disability, in terms of does it get worse really quickly or get better? So I don't know if, talking about more, policy or system, everything we do, I guess, or most of it, is on the individual. We have to know what we, then how does that play with a more broader systems?
I think you raise a good point because know quite a bit about the informal support system, but we do not know our family, delayed referral network, how folks make their way into the healthcare system, as well as long-term care. What we know less about, though, is how the formal system articulates the informal networks and social supports. And I think that's where there's a gaping hole in the interaction, and there is a changing need for assistance as a result of how the family's ability to mobilize in response to these changes in functional capacity.
Well, that's part of the discussion from yesterday. That's why SES is the stronger predictor in the model than actual health insurance. It's having the health insurance and then knowing how to use it, or knowing to engage it. And that's an indication, a function of education or health literacy or something, in trajectories into the system, how to use them. But at the level of interventions, do we know very much from these survey data about what the motivations are in terms of, not the motivations of the individual, but how you enter into the healthcare system and having access to it are entirely different things. Like, do people use healthcare even if they have access to it? It seems to me to be a great mystery. Also, being a white male, and not going to the doctor as regular as I should. Why? Why is that? Genetic.
Well, and that raises a good point about the population because we have many more of our older Mexicans now covered, but is the healthcare delivery system there able to respond to those changing needs for assistance, especially in the absence of formal long-term care supports? So when we think about access versus coverage, we need to be sensitive in all of our studies, and often our data don't include those measures yet.
And it is related to what Solomon's presentation, that they're now affiliated, but the truth is that first, primary care in Mexico knows little about geriatrics and how to really, look for it in an older adult. So it's sort of, being affiliated and increasing that is important. Obviously now they have at least something, but then how is the system really managing that?
There's such a long duration for manifestation of those symptoms, and when do you know to intervene? That's important. Any other gaps that we want to try to fill? Yes, Steve.
So what struck me, a lot of people touched on measurement, and so the presentation on the different ways of measuring disability, I'd never thought of before. So like the aha bulb went off, because there's so many areas. So the cognitive, at the end, how do you measure cognition? The MMSE, most researchers have thrown out, but is there really equivalence in populations, say in the US and Mexico, even in any of the other ones? And so that the disability measures, there seemed to be a gap in the percentage saying no, they're not disabled, but couldn't do the function between blacks and whites, between Hispanics and whites. We know South Health works different in the way we measure it in English between English and Spanish speakers. So all of our conclusions are based on these outcomes that we say, oh, but it's been tested somewhere else before, but that doesn't mean that, okay, so fine, there's a hierarchy from fair to excellent in Colombia, but is that the same hierarchy as there is in the United States? I think we need, as we're doing more international comparisons, we need more of that. It's great that there's more longitudinal data like the UMPAS, so you can actually be within persons, or so a person change over time. If they measured one way in time one, they'd be measuring the same way in time too, but then when we aggregate that and compare it to the HRS, get all sorts of questions.
Can I hear others respond about this whole issue of measurement, because we've wrestled with this over the years.
It has no solution, it's a problem.
Well, I don't know. I looked at them. Maybe I'm trying to get to some solutions, but you need to have a distributed network for the measurement properties of these things, and only through something like crowd research or lots of participation are you going to be able to answer that question. And I think all those tools are at hand to do something like that in a creative way. But have they been employed, or do we even have? My perspective is we get stuck in the same study over and over and over again. And how do you get into something more interesting? Is usually the sophistication that outstrips 12 pages of narrative.
Yeah, I think it parallels where psychiatry is right now with the regime at the NIMH. So basically saying the DSM and all that approach is bankrupt. We've had enough of this descriptive stuff. We have to understand the biological determinants of it and then build the diagnostics out of that, rather than trying to do it the other way around. We're sort of in the same situation. We can't map it onto the real biological consequences very well.
Not at all. And the WHO paper that I have out is exactly on that issue. It's a completely different way of mapping it. So I'll send you that.
You share that with us, put it on the website.
But I mean, even something biological like diabetes. So if half the people with diabetes are not diagnosed with it, and our most common way of assessing diabetes is to ask as if the doctor told you you have diabetes. I mean, that's really critical. And that proportion differs in Mexico from the United States. So once again, you're comparing self-reports of diabetes, the underreporting is not consistent.
And even within the United States, again, Hispanic populations without access to healthcare,
Right.
they go undiagnosed.
Right.
And the proportion that actually get diagnosed in the United States, there's just this, I mean, it's glacier in nature because there's almost every older adult is pre-diabetic to a certain extent. It's a spectrum, not a threshold.
By the time they get old,
Yeah,
the Mexican Americans, they can diagnose, because they go to the doctor.
yeah.
You ask, do they go when they get insurance? The older people really do. And the doctors who treat Mexican American older people, the first thing they do is diabetes. So we don't really find a lot of undiagnosed diabetes, you know. Now they actually show an increase in the prevalence of diabetes. Some of it may be better detection, right? But some of it is probably real because they're living longer and they're living longer with their diabetes. And they have more disability, which is another issue. In Mexican American part, we think the very old athletes are getting more disabled. I kind of like to think that maybe it's happening in Mexico too, Rebecca. Before, it might be really easy to look at that. Is Mexico, you know, in the epidemiologic transition state, where you're living longer and you're living longer with more disability.
But there's a real gap, like Stephen was saying, between what is an IADL and what is a first signs of cognitive decline or some other functional decline. And those early stage or pre-symptomatic diabetes, heart disease, we don't measure those very well. We don't really know what's going on. But we are.
Well, some lab values can change depending on the lab that's used. So, can be tricky that you can get changes over time. It could be due to changes in labs. And I was thinking through of the contrast between Mexico and the U.S. and wondering how much of that was real versus how much was it different. Was it different labs and how they were actually evaluating it. So it makes sense to try and get consistency all those three.
And then we can raise it to another point about, are these sort of methodological artifacts that you're seeing in terms of these estimates? It's hard to identify those other than speculation, so we need to pay closer attention to that. Well, I'm going to go ahead and move on to our most important research areas that we think of in the future as we plan, just in terms of after some reflection, what you're going to take from the meeting, but also where we want to go in the future. So what comes to mind? I'd like to actually do a round robin and have everyone be able to contribute. So we're going to start.
What is the research priority in the field of aging
Yes.
in the Americas
Yeah.
or US?
I'm going to start with you, Mauricio.
I will say cross-cultural research to see, to try to disentangle if it's genetics, if it's lifestyle, so we could compare lifestyles within different countries. I think I will go with cross-cultural.
Social behaviors, health behaviors.
Yeah, to be able to see where is the difference. Because if we only study immigrants here, we are studying people that are living in the same place. So we have to study the same genetic pool in a different place.
Sure.
Do you want to ask?
Okay. I have a special worry about this because I have always wondered how can we pass all of this information to the people of the government, the people who really take the decisions. So I really would like to find a strategy to find that possibility, like the ways to find that people listen when we have. It will be really great that here would come some people from the government that listen of this information.
So dissemination is
Translation and dissemination, we're fine.
Yeah.
and really amp that up. We continue to work on that. It's a very important issue. Yeah.
I was just going to say that the appreciation from Colombian and Costa Rican fellows that I want to highlight now that I've been in Costa Rica for a while, other Latin American nations are relying on the United States to generate research that helps them guide policy in country. And that's something that is lost often.
As we expand our plans.
Well, I mean, probably somewhat along the same lines. I would like to see a lot more in terms of how policy context in all of these different societies, given that they're very different from developed in the United States with very established policy context in terms of social security, healthcare, to Latin American countries where it's fast evolving from very small to more universal, and how they interact then with both individual, family, and group behaviors. And so I think it's a very nice laboratory, or almost, because you have all these almost natural experiments occurring across countries, and there's a lot of spillovers in terms of knowledge, because all of these countries are looking at their neighbors, and then the United States as the biggest country in the Americas, to see what others are doing and what can be implemented.
So understanding that public-private nexus supports.
Exactly.
Yes.
Well, I'll go back with the other policy that said that we need more cross-country comparison, because now Mexico is experiencing all these processes. Mexicans coming to the U.S., facing this new context, and in a few years probably Guatemala or other countries in Central America are going to be through the same process and experience all these things. So we need to understand really what's happening in Mexico, so we can provide them with information to let them know what they might be facing in a few years.
So we can exchange.
Hi. I think for me, we're hearing a lot about like these diseases, diabetes, all these negative health outcomes, and I would really want to know about the quality of life of the older adults, and in my thinking, intervening to improving the quality of life, because these weigh heavy on them. I know being unhealthy is difficult. And then you live with it every day, so that would be something that I would be interested in learning more about. And in that same line, the measurements for it. I think we have tools validated in English. I think we need tools validated in Spanish, and that capture this adequately.
Great. Good. Let's keep going.
Piggyback on the intervention side, I think it's important to learn about more interventions done at every single level: policy level, environmental level, community level, individual level. Because I feel like that's the only way that we're going to be able to address all these challenges.
So I feel like What my PhD students have said is, which is not too surprising. But, I think I've said to other people here that what we do is a little bit different with randomized controlled trials and health behavior intervention. But the information that I've learned is really helpful for like the introduction sections to help create the rationale, for discussion sections to help us make sense of the findings that we get, maybe to analyze data differently using some of the stuff we've learned here. I do think that intervention is important, using everything that we've learned here and from this group, up until now, so that we know how we can intervene, who is it most important to intervene with, who's most at risk for different chronic diseases or something like that. So that's what I would say is important.
Interventions, good. Yes.
I think to build off of one of the facts that we learned would be to look at the intergenerational impacts, but the multi-directional intergenerational impacts, and also similarly how those impacts could have spillover effects onto different trajectories, like trajectories of we looked at education and health and economic.
Well, I think I'd be very interested in seeing us look at the context in Mexico and context in the United States of people who are low income in terms of how they receive health information, how they use health information, and how that has a relationship with the use of healthcare systems. Because the issue of health literacy pops up as a chronic issue, and it seems to have a relationship with behavior in certain very specific ways, in terms of health-seeking behavior, self-management behavior. And we don't really understand what the differences are, across these contexts, especially in a situation with various social barriers in the way, such as lack of resources and the inability, the low educational levels, etc. So I think it's very important to understand that if we really want to get into the nexus between what we learn in standards research and cross-sectional stuff and longitudinal research we do with big population surveys, and what we understand are the needs of healthcare systems to do a better job of reaching these populations. So I'm just trying to bridge that gap a little bit and move a little closer to that
It's a
point.
huge gap to fill. It's something that we need to definitely think about for the next install. We're actually on our third question here, in asking your opinion on what you think the most important research priority in the field of aging in the Americas, U.S., Mexico, and Latin America, based on what you learned these past few days throughout your studies.
One of the things that I wanted to highlight, which is what Casio did with the mortality by socioeconomic status and the lack of data that is in the rest of some of the other Latin American countries. But it seems that some of those countries have surveys that would allow us to get some prevalence or some values at the national level, say by socioeconomic status or other markers. And now we created some mortality database in Wisconsin that I think will allow us to start making some of these links, particularly for older people that we seem to know very little, particularly also with older age mortality that we seem to know very little in Latin America. And as these transitions keep moving really fast and people seem to be living longer and longer, I think we know very little in Latin America how long they are really living. So I just wonder if we could also start using more of these national level data that is out there that we haven't seemed to be exploited yet.
We have a lot of work to do to try to understand this ALE outcome, paradoxes. Steve?
So, I don't think there were any presentations in this meeting about the institutional context that older adults find themselves in, whether it's healthcare systems, so there was a comment about how do healthcare systems in Mexico even offer diabetes screening routinely. The churches that people belong to, the communities they live in. So keep in mind this is a largely demography group. I'd like to see more multi-level modeling where you're actually looking at not just individual outcomes, but individuals within health systems and maybe even health systems within societies. And that could give us some ideas about interventions at a more population level as well.
What kind of data would that take? Data set?
Well, probably not any existing data, so there's another grant opportunity. But I think if you're saying what are the questions, what do we need to do research on, that's an area that there's a big gap.
Well, if you think in terms exclusive in terms of Latin America, I would add to what Ira said. That's probably what we need is to try to build some international, some project that can provide international comparison. And this is very hard, of course. It's hard because it's difficult to put people talking about the same thing, even within the same country. So if you go to Brazil, there are demographers doing things on health and mortality, there are people from public health doing the same thing. There are a lot of overlap, even if you don't talk. And you get the same is true for the US, the same maybe is true for Latin America. So I think so there are different dimensions being studied here. And one way maybe to go would be to try to look at simple things like it's simple. It took a lot of work. Because mortality is the simplest method. Yeah. But I mean the international comparison. Now we have it. I mean, for the whole for a bunch of countries in Latin America, we have comparative data. That's very important because then this allows us to do comparative studies. We need to move that from mortality to social determinants of mortality, to biological determinants of mortality, and then to health. So, of course, when we move into this direction, we're going to need more specific data. We need to collect the data. And there is an effort of making MHAS, the experience of MHAS available in other countries, including Brazil. So I think this will help. But we need to use the network to work together in a consistent way. That's what I think is how but in terms of the Latin American, that's what I understand. The Mexico questions are the most important for the U.S., for Mexico and the U.S. But I think there's a lot of opportunities to move beyond Mexico to other countries.
Yeah, so I would focus on some of the issues that I raised in my own talk, which is focusing on Latinos. I don't think we have a lot of information on the psychosocial living. So really understanding what the stresses are, getting a sense of perceptions of anxiety, a sense of locus control, optimism, pessimism, what the primary factors are that are making it difficult, what the extent to which people have life satisfaction, how that varies between undocumented immigrants, documented immigrants, and upper generation, higher generation Latinos.
The much more detailed immigration information on the psychosocial living.
Right. I'm assuming so some of that's been covered, but it seems like the social stuff is really necessary. And then I apologize that I just have to read these.
Thank you for all your contributions to really stimulating and very helpful.
I thank everybody very much.
Well, I have 2 points. One is, at least for Latin America, I think psychosocial well-being is something we really need to focus about. Because you find people 65-year-old in Mexico, it's like, probably because they have had a very hard life. So I think we be great for Latin America to know more about this. It's hard, I know, to measure with vocation level surveys. I think what's the best measure, and it's a scale or another thing. But I think that would be important to focus on. And my other point, related with what has already been mentioned is, and it's a question, is could we learn, or what could we learn from the oldest old, like centenarians or 90-year-old? I mean, especially for Mexico, being 90 today means you were born during the revolution, the country was, very, mostly rural. So these people had, very precarious conditions. And they're here, they're there, but they're other places. Or here too. So I don't know, and probably you don't see these obviously with national level data because it's like 2 centenarians. But I think we could, learn a lot from the oldest old in our countries.
And you're bringing up the point here where we both need, for some of these questions we're wanting to answer, we need qualitative data, we need localized studies, we need national surveys, detailed measures on immigration history, which in ancient really does not exist. Yes, it's going to get these things up. Cocos, do you think,
It was nice to hear comments about health behaviors, smoking, exercise, alcohol. What about diet and nutrition? That's probably the number one factor that is leading to higher obesity rates, both in the U.S. and in Mexico. And I'm talking about Americans, white people, and Hispanic and Black. We don't know that very much about diet and nutrition. We never touched it just because it's so hard to study in our studies.
well, we have the Hispanic Hanes.
I know.
The Mexican.
It's really hard.
Where's the literature connecting diet to?
The problem is it's all longitudinal and it just gives a point estimate.
Yeah, but you can study trends in the diet.
Right, and
I haven't seen a whole lot.
You're absolutely correct, but at least it gives us some information to start from. Rebecca?
Well, something that hasn't been mentioned, I think, although a little bit brought up, and it's related to what we're thinking as new content for the Mexican Health and Aging Study. It's what the NIA-related sister studies are pushing, right? Because where the field is moving and so on. And it's related to psychosocial.
Yeah.
So what we want to understand, the very poor people, why are they surviving to age 98? We want to understand why immigrants are so well behaved or survive, right? Why do they not smoke, etc. So it's got personality traits. So we're looking at personality traits, something that makes you go to the doctor, or if you can't go to the doctor, live healthy. And if the doctor tells you to take this medication, you take it. And if the doctor tells you to take this vaccination, you take it. And so there's some concept that we're studying, and the people from UPMB know that we're reading the literature right now about, they call it conscientiousness. The literature has different names, but in general is something like, well, what I just described. A person who, if he's told not to smoke, they probably won't smoke. Or if they're told you have to take this vaccine, they will take the flu shot. But it has to do with, and then there are many batteries to measure it, so we'll probably want to talk about it in the next year because we're going back in the field in 2015. And so just to share that we are pushing more psychosocial and personality traits, in particular personality that promote good health.
And patient compliance.
Right. Compliance to treatment, that kind of thing. So I think we would, to finish the thought, is that we would probably want to know more about that among Hispanics in the United States.
Another comparative.
Right.
So maybe an HRS something.
Tying on a couple of things that people have mentioned, I think we need to, people have talked about, a better understanding of interaction with the different institutions related to care, also related to documentation status. I think that we need to basically better understand how trajectories really affect the health of older adults, in the sense that many surveys, including longitudinal ones, that are relatively short panels for the most part. There's some that are longer panels, like the Hispanic FPs, but even then you start with a baseline at age 50, at age 60. And one loses some of the prior trajectory that explain, for instance, why healthcare access is not so relevant at age 60, because there might be heterogeneity and so on. So in some ways, I was, looking at some of the studies that people present, in which they didn't only basically cut down their populations at age 60 or 50, or looking at older adults in general. In some ways, I was trying to think of what are the implications of some of those results for aging, but on the other hand, it also made me think, okay, we also need to understand obviously these trajectories better, because a lot of what we're measuring, a lot of what we're not measuring, I think explains why there might be lower socioeconomic differentials as well in old age, not only because of the mortality selection aspect of socioeconomic differences, but all of these things, which means, collection of new data, perhaps, or at least trying to get better retrospective data for certain key components of the immigrant experience or the family experience, right? All of this family information and reformation.
Yeah, quick technique. Well, I mean, I can say the types of things that I'm interested in looking at are similar to the ones bringing up. So in the Costa Rica project, we're looking at these psychosocial determinants of disability and cognitive disability. Those are the things that I can grab onto. And so building on the PRELIS data on the mortality advantage, we've been looking at the psychosocial determinants and how they predict, and diet. We have a relatively unique new diet questionnaire that we're also using in Maracaibo now, the Maracaibo studies adopted, of a lifetime of diet. So it's taking the mixed Garmias factors that he found and sort of condensing them, just saying how much do you eat fish across your lifespan at different epochs and things like this. And we're after analyzing that data now, and it's a long study. So those are the types of things that we're interested in: conscientiousness, the role of personality, depression, social network size and density, familialism. These are all embedded in it. And I think hopefully by next year we'll have some more answers about some of those, at least within the microcosm that is Costa Rica. But the next project is to look at disability and these inflammation factors and cardiovascular risks, which are typical in Costa Rica, and look at them across within a family structure and looking at genetics within families. So that's my next goal. Is I think we've done some of the determinants of these epidemiological phenomena, at least in Costa Rica, to the best we can, and we'll have some answers as that finishes off. The 300 subjects that we have. But next, moving to the biological determinants and how people are living with disability and how these inflammation and cardiovascular risks are affecting what types and the facets of disability, and trying to break this monolithic construct down to each digestible pieces.
Yeah, I'd like to mention about the mental disease and high suicide rates among elderly population. The suicide rate is very high in elderly in South Korea too, and one of the main factors for that high rate is loneliness, because they are alone. That's why suicide rate is higher in rural area compared to urban area. Well, we know how to deal with, improve their social support and social network, but I think there's a little information how actually we do that, how we intervene and increase their social network and social support. It will be a little difficult, we develop policy in government level. It should be, the policy should be developed in local level, and well, that's what I think.
And also added to that, because we see such higher rates among men than women in the United States, at least, and yet most of our research is on women. We see that in terms of intervention, to more likely to participate in studies.
Potentially more longitudinal data, that a number of the discussions have really grappled with incidence versus prevalence rates, and so to look at transitions. For disability, I think to have better measures of disability in some of the transitions. And some of it may include more retrospective questions. So rather than having more studies to look forward, to look back. So if it's a matter of saying, what kind of conditions did you grow up in? Did you grow up in an intact family? Did you have poverty as a child? Did you have problems with food security? So it goes both look forward, but also back.
Great.
I want to piggyback a little bit on what Fernando mentioned as well. I mean, so this has been a wonderful conference, and what I think I love about a lot looking forward is the generations to come. And so thinking about life course ideas of who are the elderly going to be 10, 20, 40, 50 years down the road, and what kind of social context and conditions are they growing up in. So even, if the word health wasn't mentioned in the session in the coming years or something, I mean, let's look at cumulative advantages, disadvantages, schools, issues like that across populations, across countries, to kind of push back the focus, at least for some of the conference to these kind of earlier life course issues.
Generational issues. Right?
Mariana said if we could focus at systems as well as at individuals, I think that would be important. And I've said before, access to care and insurance would be good to look at, and how people move between different aspects of healthcare on the quote long-term care continuum, including primary care, how they access their own primary care, which we talked about some, and including palliative care and end-of-life care, which there are lots of differences in how that is looked at by different cultures.
Just to add to that, in terms of sources of vulnerability, Bill, this gets a little bit to your point. We know so little about exactly the gap in the literature, about the pathways not only in the system, but also after a hospital discharge for our oldest older, we end up transitioning to a nursing home hospice. And there's been some data that from the HRS now for discharge planning that was showing actually some disparities between those whites and blacks. It's really important because under the ACA, there's going to be some financial incentives for hospitals to pay close attention to that, but yet they don't have data. So I think we're choosing that.
Well, at this point, this late in the discussion, I don't very much tag on to half a dozen people. But, I think the piece that struck me the most is that a lot of the presentations, the majority, components of what they're putting in the models, a lot of them didn't have hard medical pieces to it, and the lab data is a very strong and compelling piece that would be good to have to better understand what's going on. I think from my clinical background, I still lean heavily on understanding disability. I don't think, as a therapist, the way that we're conceptualizing ADL and IADL is still relatively crude, so the measurements there should be improved. And I also think that we really need to look at the resiliency of the population as well. So they don't spend the time only going down what goes wrong. I know everybody's eventually going to die of active mortality every time. There are some other resiliency components to disability.
I'm glad you brought up that point, because really we need to change sort of our model, really looking at the terms of healthful aging, as opposed to looking at sort of our traditional epidemiological risk models. Something to think about. Survival versus death. Yes.
So it's the pandemic. So that gets to maybe some qualitative research around what these older adults value in old age. So we say, oh, do you have disability? Do you have diseases? But maybe that's not what's important to them. Maybe it's family connection or spirituality or something else. So we're imposing on these older adults our values, and be helpful to know what their values are.
Important point. I mean, there are health optimists out there. So we show people with the same level, older adults with the same level of tissue damage from arthritis. Some are, saying everything is fine and dandy, and it can be very disabling. Others are saying no.
Well, if that's going to impact the cost of healthcare, then we want to know. If not, then we don't care.
Zach,
You're so mercenary.
Tim said not too much to be added after this wealth of ideas. So I guess I would just emphasize something that's been touched upon in the past couple of days, and that is really the importance of, when looking at the immune population, certainly the US, really trying to focus on and pay attention to documentation status. It's so salient for so many things across the condition, psychosocial variables, economic, labor opportunities, and certainly health as well. Unfortunately, there are so few data sets that currently allow us to dive into it. So really pushing for, where possible, the integration of documentation into future data collection efforts, and the integration into existing data sets that we continue longitudinally will be really important for being able to.
Well, I'm mindful of the time, but I want to make sure, thank you, that we now all had an opportunity in our round robin to contribute. Is there anything that's smoldered that we need to release?
Well, it strikes me that the one thing that we haven't really even had a discussion about in the main, which is so gigantic, is the impact that the Affordable Care Act is supposed to have on population health. And what are the mechanisms through which it's going to have that impact? We don't even discuss that here. We're just looking at populations in the abstract without any context, right? But we are, in fact, going through a process right now where we're trying to tell healthcare providers, you got to get out of just treatment business and get into communities and deal with social determinants.
Well, Cocos had mentioned the article that appeared in JAMA.
Yeah, there was something in JAMA, the Affordable Health Care Act of Latino. It was just published this week, I think.
So we need to all take a look at that. And Mariana, and also, and Stevie was gone now, we're all talking about policy context, move forward. So there's many different dimensions here, and I think our conference theme this year is really just perfect in capturing much of this, but we certainly have our work cut out for us. So thank you everyone again. Enjoy the rest of your day, and we will stay tuned because we'll give you more information about our future development. Oh, also, one last point here, be sure to fill out your online evaluation.
Thank you again, all the speakers.